Sir, you can start.
Thank you, Asmai. Thank you. Thanks. Okay, good evening to all of you. I will share my screen. Can you see my slide?
Yes, sir.
Yeah, right. Okay. Today, 2, 3 short cases and one relatively long case. And before that, in the last class, I was talking to you, somebody was asking how the basal ganglia is influencing the circadian system. Today, I told you that I will be showing the slides, 11 slides in this class. So, 2, 3 slides on this basal ganglia control of circadian system. The basal ganglia has got predominantly inhibitory control, but it also got a stimulatory effect also indirectly. That I will tell you in later on. Usually, the caudate nucleus inhibits the substance like reticulata, which in turn inhibits superior colliculus. Superior colliculus, as you know, is one of the pathway for a gaze movement. It is like this: the frontal eye field or the dorsolateral prefrontal cortex, to be exact. It stimulates the caudate nucleus. Caudate nucleus inhibit the SNR, that is a substance nigra reticulata. SNR in turn inhibits the superior colliculus. Superior colliculus is the pathway which stimulates the PPR. So the basal ganglia acts not directly through the frontal mesencephalic pathway to the PPR, but indirectly through the superior colliculus. So the action is through the superior colliculus. So what will happen means if there is a stimulation of the frontal cortex, which activate the caudate nucleus, as you can see here, the caudate is inhibiting the SNR is inhibiting the superior colliculus. So when the caudate is stimulated, it takes away the inhibition of the SNR on the superior colliculus because the double inhibition, so stimulation. The superior colliculus is activated. So stimulation of the caudate nucleus or frontal eye field results in activation of the circuit. Now, there is another pathway which is mediated through the subthalamic nucleus. The frontal eye field also stimulates the STN nucleus, the subthalamic nucleus supplies. STN in turn activates SNR. So what will happen means through the STN pathway, it inhibits the superior colliculus because STN is that inhibiting the inhibitor of the superior colliculus. Stimulating the inhibitor of the superior colliculus. So, STN stimulation results in inhibition of superior colliculus through activation of the inhibitory SNR superior collicular pathway. So, in both ways, the basal ganglia can influence the circadian system either in terms of activation or inhibition. So, the integrity of the caudate SNR collicular pathway decides whether a circuit is to be initiated or not. So dysfunction results in difficulty in initiating the voluntary circuits. That is when basal ganglia, the extrapyramidal disorders like PSP and not PSP has got other explanation also, can influence the circadic movements. So this is affecting either the frontal lobes or the caudate nucleus, which inhibits the SNR, mainly due to difficulties in initiating the voluntary circuits in tasks that require learned and predictive behavior. Thus, patients with caudate and bilateral lentiform nucleations show abnormalities of predictive and memory-gated circuits, that is both internally generated, but visually guided circuits and anti-circuits are normal or unaffected. That was the last class I told you about the one patient with supranuclear palsy. The visually guided circuits are normal, but he cannot move a little bit and ask him to look to right, left, up, down like that. I don't know whether you remember that or not. So he could not have any movement on memory guided or predictive circuits, but show the finger, he is able to move a little bit. So that is why always in exceptional disorders, you have to look for circuitry testing by doing just like I told before. Okay, that is for the regarding that part of the control of the extrapyramidal system. Now I'll go to the cases today. This is a story of a 65-year-old male It's a
Sir,
short case. Yeah, please.
Sir, PSP, the anti-saccade will also be abnormal, sir.
Yeah, that is because of the frontal lobe involvement. Because the frontal lobe is directly responsible for the anti-saccadic pathway.
Not
Okay.
via the
No,
caudate.
not by the caudate.
Okay, sir. Okay, sir.
It is actually a type of disinhibitory control. You know, the anti-saccadic test is a test of just like the prefrontal lobe functions. No, inability to inhibit responses.
Like
Okay,
a
just
Stroop test, sir.
yeah, like a Stroop test.
Response
Like,
inhibition.
response inhibition test. So that is the one which is done test by the anti-saccadic path. Because patient is in frontal lobe lesions, patient is unable to habitually learn motor act, unable to suppress a habitually learned motor act. The normal tendency is when you see a stimulus, look into the stimulus. That is a habitually learned one. But here the prefrontal lobe is the one which tries to inhibit that learned response. That is lost. So the antisaccadic and the antisaccads are affected in prefrontal lesions. They cannot inhibit their spontaneous response to look at the visual stimuli.
Okay, sir.
Okay. Now, just 1 minute. Okay. Now, this is a story of a 64-year-old male, known case of diabetes and hypertension. 2 months back, he noticed diplopia with horizontal separation and is present on looking both to the right and to the left side. He did not notice any walking difficulty or headache at that time. Horizontal diplopia, no, naturally one may think either bilateral lateral rectus or bilateral medial rectus or one eye medial rectus or lateral rectus. These are the possibilities you have to keep in mind. The diplopia is persisting even now. Now, this is how he came to the OPD with one glass covered because of the diplopia. Now, let us see when they examined him, his pupils were normal. He has got ill-sustained nystagmus looking to the left side. Mild ill-sustained nystagmus also to the right side. The movements were all normal. Saccadic movements are all normal. And I want to check the nystagmus. Keep on looking to one side. It was not persisting. Then check the ocular movements in all directions. They were normal. Looking up and down, up and to the left side, laterally to the left, down and right to the right side, down and to the left side. Then ask you to say whether 1 or 2. He tells 1. Said single. See, it's all direction is telling 1 only, but he combines with diplopia. Okay, cranial examination. Visual acuity, visual field is normal. No restriction of was noticed in any direction except for ill-sustained nystagmus looking to both lateral gaze. Rest of the cranial is normal. So what do you think what the patient is having?
Cerebral polyopia, sir.
Okay, but cerebral polyopia will we have diplopia also, even with both eyes open. You say diplopia when it gets in close one eye disappears. Any thoughts what will you like to do in this patient? And let us see what I did. You look very carefully now. He said 1. 1. 1. He said double. So when they move the finger far away from him, he sees double. Okay, I'll show the video once again. He's telling single. Look at his finger. He's doing single. What? is a two, is a double. So what is the diagnosis now? I'll show once again the other and the video.
Sir, is it some kind of hemifield slide?
No. It's not a Mayfield slide phenomenon. That can what is also diplopia looking distance object, but classically the midfield side phenomenon, there is overlapping of the images or separation of the images. This is a diplopia looking at distance.
Convergent spasm, sir.
In convergent spasm,
So is there any weakness of the lateral rectus, sir? So
yeah, so when you get diplopia looking at a distance, the first possibility you're thinking lateral rectus weakness. Convergent spasm can theoretically cause that possibility, but first lateral rectus weakness. But the problem is that when looking to the left side or the right side, he has no diplopia. See, if it is lateral rectus weakness on the left side, I should develop diplopia looking to the left side. And also at distant object. If you got right lateral rectus weakness, diplopia looking to the right side, as well as looking distant object. But to the right and left, he has no diplopia. Only at looking far object, he has got diplopia. What is this phenomenon or what is this problem with?
And middle rectus palsy like this.
Again, the problem will, in that case, the diplopia should be more on looking to, again to the one side, but on close quarters. But he has no diplopia looking close quarters. The diplopia looking at far objects. So it's unlikely to be made. If at all, it goes with the lateral rectus rather than medial. Okay. And what investigation you want? I'll tell you the syndrome later on. He has got, see, this is MRI. But in fact, is an old hypertensive person, in fact, in the pons. Also one, in fact, in the crucible on one side. And in the old lenticular, in fact. So this is what is called divergence palsy. Normally, you all know about the convergence, no? When the convergence is when the eyes adduct when it goes most towards the nose. Similarly, when you look at a far objects, the eyes will tend to diverge. That is called the divergent movement. We always talk about the convergence center, but there is also a divergence center. So when that is affected, you get this phenomenon. Now, how to differentiate from lateral rectus palsy is that there are no diplopia looking to either direction, only on looking at far objects. That is, parallax to divergence is a condition in which distant objects appear double. Diplopia is present in horizontal plane, does not increase when the test object is moved to either side. The double vision is less evident at near point as near point is approached. Because there, in that situation, there is no need for a divergence. The diplopia with paralysis of divergence is due to lack of divergence of the eyes, which normally occurs when an object is viewed at a distance. The lack of divergence is not due to the weakness of an external retinal muscles, but because of the apparent impairment of their function by divergence testing. Divergence. Now, a little bit about the physiology of divergence movements. So, divergence paralysis is reported patient lesions involving the paramedian and left inferior portion of the pontine tegmentum. This patient had lesion in part of the pontine tegmentum or thalamus or the midbrain. The recent studies, however, have proposed a divergence center within the pons. It's called the nucleus reticularis tegmenti pontis, which probably has a connection with the deep cerebellar nuclei. The NRTP, the nucleus reticularis tegmenti pontis, affects convergence angles and increases firing rate for both near and far responses. The divergence eye movements are either slow or fast. There is slow movement or saccadic movements. The NRTP is mostly involved in the smooth pursuit and slow divergence. Lesions involved in the NRTP impair the slow vergence, especially divergence, while the fast divergent movements are related to other pontine nuclei. That is why NRTP nucleus is postulated to be the site of lesion for divergent paralysis. It's all from there are cases reports like this. So any questions?
Sir, can this happen with a patchy meningitis?
No, whatever be the pathology behind it, the lesion should have the pons. The patchy meningitis compresses the pondine structure by a ischemia due to compromise in the vessel supply. That definitely it can produce.
Okay.
Why only left side is given, sir?
Pardon?
Sir, left inferior pontine tegmentum. Why alone the left
No.
side is given?
No, that is what they reported it. Now, this is from the literature only. The evidence in the pons, the nucleated body, which probably is, this is what I written. NRTP.
So the first line states that.
That's the case reports. Case reports.
Okay.
There are also case report telling that the midbrain also can produce. These are all postulates, no? These are all, they have found lesion on one particular site and they have found divergence palsy. And somebody postulated this could be the site of lesion like that.
Okay.
Any questions? Shall I go to the next case?
Yes, sir.
This is a long case. This is a story of a 29-year-old male. Just a moment. Story of a 29-year-old male. He's a technician working in the Gulf. His complaint started as pain in and around the root of the penis, followed by difficulty in passing urine 6 weeks back. 2 days later, patient developed vertigo, followed by altered sensorium, and was unconscious for the next 11 days. He was admitted in a hospital in the Gulf. When he recovered from his comatose state after 11 days, he noticed diplopia, dysarthria, and total inability to move both lower limbs, and he was on a catheter. Over the next 7 to 10 days, diplopia and dysarthria improved, but there was no improvement in his weakness of both the lower limbs. In the past, about 3 weeks prior to his illness, he had fever and URA which subsided. He is now admitted in the present hospital since there was no improvement in his lower limb power. I'll go back to the story once again. He first developed pain in and around the penis and then retention of urine. 2 days later, patient developed vertigo, followed by altered sensorium, and was unconscious for the next 11 days. He was admitted in the Gulf. When he recovered from the comatose state after 11 days, he noticed diplopia, dysarthria, and total inability to move lower limbs, and he was on a catheter. Over the next 7 to 10 days, diplopia and dysarthria improved, probably brain cell symptoms improved. However, the lower limb weakness did not improve. Then prior to the onset of all this episode, he had a fever 3 days, fever and upper respiratory infection 3 days prior, 3 weeks prior. He came here since his weakness in the lower limb did not improve. That is why he came to the present hospital. So this is the story and examination. Now the KNS are all normal. There was no abnormality detected. His hand grips are mildly weak bilaterally. The proximal muscles were all normal. Triceps deltoid were normal. The finger abductors are mildly weak. There's no finger nose incoordination in the upper limb. He could not get up from the bed. He could flex the neck without much problem. Power in the neck appeared normal. But he cannot turn the body, get up into the sitting position or bending the trunk. There is hypotonia in both lower limbs with wasting of the anterior compartment of the muscles. A zero power. Zero power. He could not know anything. Now, the abdominal muscle is also weak on the upper and lower quadrant. The upper limb reflex were well elicited to the viscous side. The finger flexors are also well elicited. Lower limb reflexes are all absent. Plantar was mute. With his sensation, he is able to feel the touch the upper limb as well as the lower limb. He couldn't hear it. He is able to feel that sensation. Pain, he was not able to feel in the lower limb, and he will tell you the level where he feels the pain. That's the area where he feels the pain. Whole abdomen you are not able to feel, abdominal fluids are absent. He feels, I'll show you when he feels the pain. There he is able to feel the pain. Near the lower rib cage. US when was negative. Vibration was able to feel in the upper limb normally. Knee also is able to feel normally. But over the toes it was absent. Angle it was able to feel. There he is not able to feel. Joint senses normal in the upper limb. Lower limb it was absent or impaired. Is wrong. What I told was wrong. Again made mistake. SLR was negative and the perial sensation was absent and anal sphincter was loose. So an examination, high bell function is normal, cranial nerves all normal, upper limb tone power normal except for the mild hand grip weakness bilaterally. Weakness of lower part of weakness of upper and lower part of the abdominal muscles. Weaver's negative. Lower limb hypertonia both lower limbs. Grade 0 power of all muscles of both lower limb. DTR upper limbs all normal on the viscous side. Lower limb both are absent. Abdominal absent. Plantar mute. Sensory touch is able to feel in the lower limb. Pain is lost bilaterally below D6 on both sides. Vibration appreciation in the lower limbs except over the toes. JP is absent over the toes. L reflex absent. Perial sensation lost. Now next steps. So where is a localization and probable etiology in this patient?
So we have to explain two levels of lesion.
Exactly, 2 level. Perfect. What is the present level? Where is it?
Present level is above D6, sir. T6, sir.
Is it a lesion?
T6, but
Is it
his
is the
cervical
lesion? Is the lesion confined to the D6 spinal cord level or?
sir, his he cannot turn around in the bed and he cannot get up from the bed. So both thoracic and abdominal paraspinal muscles are.
Agreed. Okay. Now I want a lesion. Is it in the spinal cord?
Yes, sir.
If it is so, it's only at that level or below.
It might be
Or
extending. It might be extending, sir. Lower thoracic, upper thoracic and lower cervical level, sir.
It may be extended down, sir, because the anal reflex is absent. Maybe long segment intramedullary lesion, sir.
exactly.
Because
That is
pain temperature is involved and is paid and the vibration is preserved.
right. So that's the answer. Now, if you got a complete lesions, dorsal cord at D6 cannot explain because even though he has got grade 0 power, which will make you think of spinal shock, it is not spinal shock because he has got preserved touch sensation in the lower limb. Okay, and preserved vibration in the ankle and knee. So that will not occur with a spinal shock. That means, and moreover, the anal reflex were absent. So you have to implicate that the weakness in the lower limb is not UMN, it's likely to be LMN. Because with the patient's recovered spinal shock, the reflex should come back. It has become still absent. So the only way to explain is that extensive correlation from D6 down up to the corners. Then only you can explain these patients' findings. Something like an elite team occurring in that. Okay, that is the first localization. But that cannot explain the symptomatology of his comatose state, his cranial symptoms, and his mild upper limb weakness also he couldn't explain. How do you explain that thing?
So probably brainstem pathology, midbrain pathology affecting.
Perfect. So most likely, he must have some problem involving the brainstem causing altered sensorium or a bihemispheric lesion. Altered sensorium can be due to brainstem or bihemispheric lesion. But he had definite evidence of brainstem dysfunction, like dysphagia, dysarthria, diplopia. So that tells you he must have most likely brainstem lesions there, with or without a hemispheric lesion. Okay. So what will be the likely etiology in this? The multiple level.
Vascular and demyelination both are possible, sir.
Right, vascular. But since he had a fever prior to that, most likely it may be demyelination, no?
Yes, sir.
Yeah. So what investigation you like to do? So I'll show the investigation. Obviously, you want an MRI to be done, which the MRI done in the Gulf. That is more important than the present MRI. Present also important. So this is the MRI done when you are submitted in the Gulf. It's a poor quality MRI, but I will show the one by one. This is the CD from the CD copied. See the hyperintensity can be seen in the MCP, midbrain, lateral column, cerebral epidermis, internal capsule. I'll show the much more better picture later on in the splenium of the corpus callosum. Now I'll show that this picture is little more better than the T2 axial. Secant hyperintensity can be seen in the entry part of the medulla here bilaterally. But the pyramids are affected. Both MCP is affected. Mid part of the pons is affected. The crus cerebri is affected in the midbrain. Again, crus cerebri. Bilateral lateral thalamus. Bilateral internal capsule more on the one right side. And subcortical white matter. That is the picture they done there. Then that is hyperintensity, which you can make also one by one. That is MCP bilaterally. Again, MCP and the mid pons. Crus cerebri of the midbrain. Both thalami, both internal capsule. Caudate nucleus on the putamen on the left side. And posterior part of the splenium and subcortical white mat. And this is the coronal cut. Again, same thing. You see the extensive aperture of the brainstem. This is the flare sagittal. Anterior part of the corpus callosum, splenium of the corpus callosum, thalamus, MCP. This is the T1 weighted, which is non-contributory. Shows hypodensity in the same area which is affected. And this is the T1 contrast, which they have done. But these lesions were not contrast enhancing. The spine, again, very poor quality, but you can hardly make out anything. But some of the pictures I will show. If there is some, so you can see the long extensive hypernericity can be seen in the cord. Even they're not very clear, but you can make out some hypernericity within the cord. That one. This is a T2 axial. Again, you can make out the hypernericity within the cord. I will show the static screenshot later on. This is hypernericity in the cord. This is taken the CD, that is why the quality is very poor. There is a T1 non-contributory. T1 contrast, again no contrast enhancement. So what is your diagnosis now?
Either Mogad or GFA.
Okay, very good. Mogad, something like a post-viral demyelination, like Adam-like picture. Okay, extensive. If you see in a child, you definitely diagnose an Adam. Adult also can be Adam. So one cause of Adam is Mogad. That's the one because it's affecting a long extensive cord lesion in the lower part, including the corners. That is a most commonly Mogad. Okay, so GFAP also is a possibility. But the MRI picture in brain is little different, but this picture does not exclude GFAP, but classically you find the perivascular enhancement is classical one, a linear striate enhancement. That was not seen in this patient. But then need not be there all the time. So investigation there was, they showed mild pleocytosis, protein sugar normal, blood test elevated ESR, CRP, liver enzymes. HA was negative, Drusilla negative. This is the, I only show the important finding. Their report, cervical and upper dorsal cord appear minimally enlarged, and this area shows long segmented abnormality to high intensity, spanning from C3 to C12. Sorry, D12, not C12. It's wrongly spelled. Then in the brain, several bilateral, subcortical, thalamic, medial cerebellar, midbrain, ill-defined hyperintense signal on T2 and flare, which are hypointense in T1 and no diffusion restriction or no contrast enhancement. Okay, so now the patients come to you in this state. What do you like to do? This is the previous story. What you have shown the video is the present one.
Serum enema.
Yeah, that was not done. We have to do that. Perfect. So we want to do NMO and MOG and vasculitic profile. And so a repeat MRI was taken. That is present MRI after submitted now. This is the present MRI. Lesion is still there, but much better than before. It has regressed to a great extent in the brain. Not a good quality one. This is the in the spinal cord, brain axial cut. Compared to the previous one, the lesion is still there, but much less in direction. T to coronal brain. Clearly better than before. This is the contrast axis. This is a sag contract which is done now. No contrast in spine. Now, MRI spine was also repeated. This MRI spine. Lumbar cord was normal. Some lumbar spinal cord spine is normal. And if you look at the lumbar axis, this is the lumbar axis, the low corners is affected, but the cauda equina is intact. There is no lesion in the cauda equina. Then cervical spine. Subtle hyperintensity you can make out in the middle. Some suggestion of hyperintensity, not a very good quality MRI anyway. And this is the axial cut. If you bring from above, you can see the hyperintensity within the cord. It's not a good quality film, but some suggestion of hyperintensity in the cord. Contrast was non-contributory. Dorsal spine, dorsal cord. You can make out the hyperintensity in the cord. I'll play it once again. See the hyperintensity can be, see the hyperintensity which is still persisting in the lower spinal cord. You can make out that hyperintensity there. This is the axial. There's hyperintensity in the cord, including the epiconus conus region. These are all, this is the epiconus region, conus region, epiconus, that's hyperintense. So, in a sense, hyperintensity is little less, but the spinal cord, both in the brain and spinal cord is less, but it's still there. Now, what are the tests you need? This is in MOG. No? So the test was done. ANA profile was done, which is negative. MOG antibody negative, NMO negative. ACE angiogenesis is negative. In fact, there is no contrast and that's likely to be sarcoid. So it was lupus anticoagulant was negative. Cardiolipin antibodies were negative. Now, what do you think? What do you test a diagnosis now?
Is the patient progressing, sir?
No, and this is the state he came to me when I saw the health follow-up later on. Not progressing, because he was in the comatose state, and on recovering in the coma, he had multiple cranial involvement. They were all subsided. Okay, his upper state, even though white matter shows hyperintensity is clinically normal, as far as the cortical functions are concerned, as to the brainstem functions are concerned, upper limbs also concerned. What is not recovered is from the spinal cord lesion, the extensive one coming up to the epicondyle, not recovered.
Post-infectious Adam.
Yeah, it's post-infectious Adam. MOG negative, but so this entity is now called something mimicking strongly like MOGAD, but MOGAD negative. This is more common in children. They call it post-infection monophasic immune-mediated demyelinating non-MOGAD CNS disorder. That is the term they are given for it now. This can also occur in younger adults. This is the term. We don't usually see in adult, but can occur in adults. It's a non-MOGAD Adam. Classical non-MOGAD Adam is a post-infection monophasic immune-mediated immune disorder, seen mostly in early childhood with involvement in the brain, spine, and sometimes optic nerve. Spinal lesions are mostly LATM involving the thoracic cord. Brain lesions are asymmetric. This is from literature. Bilateral, large signal hyperintensity, fluffy in appearance, just like our patients. On FLIR or T2 weighted MRI, involving brainstem, cerebellar white matter, as well as symmetrical involvement of the thalami and basal ganglia. Exactly the same picture what we have seen in our patient. Gadolinium enhancement varies. So that's the story. Now, in the hospital after admission, I put him on rituximab with even the second after two doses. I mean the initially we get 2 injections. No, after the second week injection, I saw the patient again. He had shown improvement in the lower limb. He started moving the lower limb, become about 1 to 2, not 3 plus or 4. But the sensory also improved. Power has started improving. He's able to turn around the bed now.
Is there an indication for rituximab in such cases?
Definitely, because the patient has not improved. See, they are given there in the Gulf. He was given IVMB, and then the CNS part improved, spinal part did not improve.
What is the cause of pain around the root of pain is in the beginning?
That is the first one. You got it. Lesion started in the cord first. The epiconus, conus is the first area affected here. That is where the pain is occurring in that area. The crossing fiber is affected in the spinal cord. Then he developed altered sensorum and everything. So he started at the conus and subsequently affecting the brain and then became comatose. We do not know what all the progressions happened during the comatose stage. When he recovered completely, he found the lower limbs has 0 power.
Rituximab, how long to continue a single dose?
Just like, pardon, yeah, and just like our any, how long to treat all is arbitrary. No? So in immune-mediated diseases, we try to continue that with shortly recovering. Then we'll wait for some time. In the case of, if it is a MOG, we know there is some guideline we can say after 6 months MOG negative, we can stop and taper it down. In such conditions, normally it's like a monophasic illness. So once the recovery has occurred, you can stop it. Unlike MOG or unlike NMO, NMO require lifelong treatment. And certain NMOs require lifelong treatment. Some of the NMO does not require that. That depending upon the level of the MOG level after 6 months, 6 months of treatment. Even there are cases where MOG negative has become positive again. That's also situations are occurred. No, so in this case, this is a monophasic illness. So there is no need to continue long-term rituximab or anything. One course or second course and then stop into that.
Sir, in this MOG negative LETM also, sir, used to give rituximab?
If it is, yes, of course, you give that. The problem is, if they do not, of course, first thing is we give IVMB. The patient does not remove, you have to go for rituximab.
Rituximab. So usually we are giving initially IVMB followed by plasma.
Yeah, that the IVMB, and in the fulminant cases, you can combine IVMB with plasma and IVIG also. That also is possible. You can even combine both the things together in fulminant cases. If they do not respond, then you can extend it only rituximab.
What about patient? I have a patient actually with the conus myelitis. Patient came late actually. So treated with methotrexate, patient improved. MOG was positive.
Yeah.
Patient completely improved.
Yeah.
I didn't give rituximab. Patient is having no symptoms till now. But after 6 months, I repeated MOGAD is still positive. Then I need to give rituximab, no? Then
no, they need to be given rituximab or some other immunomodulated treatment.
If the patient recovers completely also in MOGAD, first time illness, no? Only monophasic.
Yeah. After 6 months, if the MOG antibody is negative, you can stop everything.
Otherwise, you have to.
You have to continue. The problem with MOG is I can still remember. This is why mistake I did earlier. This particular patient, at that time MOG antibody was not available. Only you had a elite team involved in the Congress. Usual treatment gave. Subsequently, when the MOG antibody came, then in the MOG that was positive. Then I stopped the treatment after some time. Then he had second attack, and from that attack, he never recovered. Weakness improved, but the bladder and this thing never improved. For the last 5 years, still on a catheter without any. So I do not know how to predict. Invariably, NMO, from the first shot, it will start to do some continue lifelong.
That's it. The
So
Mogad is a
NMO
problem.
also, Mogad also, we cannot predict which one behaves badly, which one does not behave.
Common presentation is optic neuritis. They'll come with optic neuritis.
Yeah, they
MOG
improve very well.
They will improve, but MOG will be plus minus, like mildly positive or moderate positive. What will you do? You have to give rituximab.
No, steroid only.
Steroid
They
only.
improve very well. These things, they improve very well. This Creon also, cryptogenic also, they go to steroid, or maximum you can give mycophenolate. That is enough. But those affecting the epiconus region is the one I'm little worried about. Because seeing that patient subsequently, I will feel that we shouldn't have stopped. That if we are recovered, okay, we're happy. When the patient does not recover, we feel that we should not have stopped. That's a feeling we get.
The LETM MOG negative, it is our practice to give rituximab, or is there some?
No, it's not. No, it's not a practice. It's a bit did not improve with steroid, then we go for this. This is what happens in this patient.
Guideline. I haven't seen any guideline. It is our practice, no?
No, it's not a guideline. For example, there is no definite guideline for anything. Even MOG also there's no guideline. See, MOG affecting the brain or optic nerve and MOG on the spinal cord. Theoretically, treatment should be the same for all. Then why are you very concerned about the corners? Because we know that those affecting the corners will not improve. It will be a lifelong problem with them. But other things, MOG affecting other areas, they improve remarkably well. That is why the concern.
The patient is presenting very late. Then also we can. This patient presented 3 weeks later after the onset.
1 month, with 1 month after the onset.
1 month. So how long if the patient suppose presents after 6 months, and there is a persistent residual paraparesis?
If it is
So
MOG
at that
negative,
moment, MOG negative, this patient.
negative, there is no indication for giving treatment.
Yes.
Because it's a burned out, it's a sequelae of the sequelae, no? Again, in those situations, normally one should try even steroids will try, because with the hope that some immune mechanism may be still operating, we hope that if we control that, the patient may improve. The problem here is that nobody can arbitrarily, even whatever the people say, how can be certain? Suppose you've got a brachial neuritis. I'll tell you about classical example of brachial neuritis. He has come to you after 6 months with the wasting of the muscles and residual weakness. Logically, there is no absolute meaning in giving a treatment of steroid at that time, correct? Brachial neuritis, sequelae wasted, what is the point in giving steroid? But I'll tell you, I have given steroid, found improvement. Don't ask me why I given this steroid. It's only because nothing else to do. He's not a diabetic, so I thought I'll give a shot of IV MP and let us see. He improved partially. So something which you cannot explain many times. All this said and done. Okay. Shall I go to the next case?
Yes, sir.
Okay. This is also not a very good case, but there are certain points which will be useful for a practical practicing neurologist. This is a story of an 82-year-old diabetic old man. History of imbalance while walking for the last 4 years, which got worsened for the last 2 years. No history of any loosening with chapels or difficulty in putting chapels. No numbness and paresthesia. Okay, no sphincter problems. No upper limb complaints. He has consulted many persons around the state. The upper limbs are all normal. The lower limb, hip flexion was normal. Knee extension is normal. The maximum force with mild weakness of dorsiflexion on the right side. Left was normal. Left THL normal. ALD weak only. The right was weak. Plantar flexion was normal. Hip abduction testing was normal. Flexion was also normal. Hip extension is normal. When lying on one side, he's got mild weakness in hip abduction. This thing with the point can push it down. Whether it's really weak or not, I am not sure. The angle checks were just elicitable, 1+. But angle checks were absent. It's also diabetic. Plantar was mute. X-ray normal. He said he's impaired vibration the right picture. He says there.
Not sure.
Johnson's is impaired bilaterally. And look at the gait now. He's able to, Romberg's is negative. Is the gait of the patient. He walks slow. Dorsiflexion is weak, even though totally normal. He could elevate the foot a little bit from the ground, but he could not fully full normal. Plantar flexion also a little bit present. See this? Not normal entirely. That is from standing on left side is okay. The right side smile positive from Cori positivity of tendon back test. So findings compared to the lower limb. Tone normal, normal power of both hip flexors, cortices, and adductors. Hip abdomen weak on the right side, tendon back testing. Both dorsiflex, plantar flex, AHL weak on standing on, not fully mild weakness. DTR both lower limbs, both knee jacks elicitable. Angle jack absent, plantars both indefinite. Sensor system touch pain normal in lower limb. Vibration normal in the left foot, impaired on the right big toe. JPS impaired on both toes. Normal Romberg's negative. Gait could not walk on toes heel properly, but he can still walk like that. So where is your localization?
Inversion, eversion, sir.
I did not check that particular.
Any root pain, sir? LFS.
No, yes, absolutely. See, he has been having this problem for many years, and he has been roaming around with doctors. See, everyone, I've also telling you, you have no problem, he's nothing wrong. But he feels he's feeling imbalance. But doctors are convinced about his imbalance. For 3 years, he's complained. . There's no root pain, no paresthesia, no nothing. The only problem if he is walking is now I am not able to walk properly. That's the thing.
So only walk or when he stands also, when he only walking is his problem, sir.
Only walking. Standing is not no complaint. The rhombus is also negative.
Sir, is there any his problem lies with the both lower limbs only, sir?
Only
Lower
lower.
half. Lower
Yeah.
half. Lower half.
Yeah. Correct.
So is he bradykinetic, sir?
It's not a brady. So do you think it's a bradykinetic game?
You are little bit slow, no, sir?
It's slow. Very absolutely correct. It's slow. But he has no other features of Parkinson's. So upper limb,
Yeah,
no
yeah. It
kinesis,
doesn't even,
basis,
and yeah, there is no urinary incontinence.
nothing, no incontinence, no incontinence.
Can it be only diabetic peripheral neuropathy with large fiber involvements?
Yeah, that's
with some gait problem with a chronic L5 radiculopathy.
Yeah, that's also a good possibility. But welfare radiculopathy, you are not very sure. Only thing is abduction is weak. So that's a possibility of welfare radiculopathy. Or it will be LFA-S1 radiculopathy alone. With or without peripheral neuropathy. That's also possible.
Okay.
Just pure peripheral neuropathy difficult to explain is hip abduction weakness, if at all is present. Okay, so it's a tough case. Okay, so what will you like to do? This is what I thought initially, LFA-S1 radiculopathy. Because it's whatever finding you got. So what test you need?
NCV?
Pardon? Sensory?
NCS.
NCS, yeah, NCS, and I'll show the NCS also. Before that, I did an MRI. That is
MRI
my
lumbosacral.
Yeah, this is lumbosacral MRI. I can show the MRI. So whenever you ask for MRI, this is on the we usually write MRI LS fine. Don't write like that. See, if you want to concentrate on L5S1, says them concentrate on thin cuts. This is how I'm planning that. In the upper part, I'm not interested. So there they are taking large length cuts. But lower part, L5S, they cut thin cuts. That is what specifically asked for, otherwise you will miss the lesion. So that this is only practical point I'm trying to maintain whenever I write the request. So this is the axial cut. Actually, one by one, L1, L2, L3, and L3, L3, L4. Again, since it is a thin cut, I'm showing many cuts at the same level. Again, L4 level, L4, L5 level, L4, L5, L5 level, L5, L5S1, L5S1, L5S1. That is S1. Okay. What do you want now?
Is there any clumping of the roots, sir?
Clumping is not there. See, they're all separate. See, the roots are quite separate. No clumping. It's all separate.
But in L5S1, there is some sort of intensity, sir, inside.
Intensity mean?
I mean in the root area, sir. The inside the pod area. No, this is the root area. L5S1.
You mean the cord area?
Pod, yeah.
No, that's normal.
That is a normal, no?
That's normal, MRI. That's normal.
Okay, sir.
But anyway, that's a good thought. Whenever don't find a root lesion, always go to the segment also. I should go for the segment level if they are not finding observed in the root level. So what do you want now?
On NCS study, sir.
It's NCS. So NCS was done. This is NCS. Perineal amplitude 2.7 on the left side. From the right side is not elicitable. TA pickup also decrease on the right side. Then tibial decrease both sides, more decrease on the left compared to the right. Then sensory potential is normal. FA latency is prolonged on both peroneal and tibial. Now, what did you like to do?
The CSF.
He has been having this problem for 4 to 5 years. Only walking difficulty, nothing, no progression further.
Physiotherapy.
Pardon?
H reflex, sir. H reflex to localize.
Yeah, right. H reflex is prolonged bilaterally. FA is also prolonged. H also is prolonged.
CSF may be worthwhile if CASP is considered.
Yeah.
But the problem is only confined to both the lower limb distal part.
Yes, sir.
Right.
Upper limb is normal.
Upper limbs normal.
Okay.
Contrast, sir. Contrast of the lumbar sacral plexus.
Okay, but that's a good possibility. Everything you do. Okay, contrast can be done.
Focal DSC.
Pardon? But in contour pathology is the recurring con.
Focal CADP.
Focal CADP, yes, but remaining static, almost static for many years. It's walking difficult according remain like that. It's not no. Recently it's still slightly worsened. That is telling. That objectivity is not there. I'm just telling is working like that all the time.
It is predominantly motor, sir. Could it be multiple modalities, multiplex like picture? This side, that side. Both lower limb. Motor.
That's a possibility. But again, very unusual site for a multifocal motor neuropathy presents. Usually start in the upper limb and age group is on and not progressive, except for mild progression recently. Confine only that area, not going beyond the distal part of the lobe. Okay, so what will you do now? I'll want you to look at the gait once again. I will show another video. This video I showed some time back, long back. Look at this patient's gait. Do you think the gait is almost similar to this patient? Look at the gait of the patient. I'll show the gait. Let us see that. See the gait of the patient. When asked him to walk fast, he could walk fast. See, look at the gait now. Keep that gait in his mind, in your mind. Look at the knee. Okay. Okay. Now see this on the patient which I have shown. Is this something similar?
Forefoot dragging.
It looks like dragging, but the knee is getting bent, no, unusually. Did you see the knee is getting bent?
Yes, sir.
Yeah, this is not the way usually patient walking. See, the knee is bent while walking about it. Okay. Now, what do you think this particular patient is having? The one I showed now, not the original patient. What is this gait suggestive of?
S1 radiculopathy.
Right, exactly. So now look at the patient, which is the second patient. Ask him to stand on toes. He could stand very well. Ask him to stand on toes. His knee flexes and he's not able to get stand at all on the toes. So this is something like plantar flexion gait. When the patient walks, the knee bend. Okay. Now I'm showing the patient once again. Look at the patient's gait. The knee is bent while walking. You walk fast also, that you will find out that thing. That means the heel is not elevating properly on the walking. See, the heel is not lifting up properly. So now what happened was, the story goes like this. So I was not very sure. I was sure about the L-phase and radiculopathy, but I did not find anything in the MR. I got confused. But then I went to kept the MRI back, asked him, I will discuss with the radiologist and get back to you. Now, what the radiologist told is a typical case of bilateral foraminal stenosis, and he showed me what it is. Now, that is why I thought I will share this knowledge with you, where to look for a foraminal stenosis. Now, look at this picture of the patient. This is what he has shown me. That is affected root, which is showing the arrow. The one root above is normal. That was thickened, and there is no fat above that root. That is a compromised root. That is on one side. The other side also same. The root is compromised. I will show the screenshot later on. The one above is the normal, but you can see the fat above and below. This is two other compromised roots. Now I'll show the scheme. This is a normal root above. Compromised nerve root with thickening here. Other one here. A normal fat seen above the root. Normally fat should be seen. That is not seen in the two roots in the middle. That is indication of a root canal stenosis. That's on the right. The other side also same. Bilaterally root is compromised. Now and there is also an osteophyte compression on the lower part, the L root, S1 root. Now look at the axial cut now. Very carefully. See that both canals are not seen at all at L5, L4, L5 level. I'll show this one. That is a thickened epiphyseal joint. See that area, you can see no canal at all. I will show the other fields. There's a facial joint hypertrophy there. And look at this level, facial joint hypertrophy. Where is a root canal? No canal is seen. See on the right side as well as the left side. Hypertrophy. Now compare with it, I'm showing another person who has come with low backache. This is a normal MRI. You can see the root there, the surrounding fat in the root canal. This central disc is nothing significant. That's totally asymptomatic in the patient. What you look for is the root compression rather than the disc bulge. The roots are all well seen, surrounded by the fat. See the roots all seen safely. Is a normal patient. Again, I'll show the normal root here and the surrounding normal fat seen above. So what the radiologist will tell you is look for the fat above the root. If it is not seen, I think it's evidence of compression. That's a normal root. They are the normal roots. That's a fact. So you got bilateral foraminal stenosis compressing both L5S1 root. You are sent to the neurosurgeon. Surgeon definitely, he said definitely there's root stenosis, he needs surgery. No, but I think the problem is we always look at the canal. We don't look at the foramen. And the foramen, we are habitually look at the axial cut, but always look at the sagittal cut. That is a lesson I have learned from this patient. Okay, so after all, look at the NCV. NCV is typical of radiculopathy. Decreased CMAP amplitude, normal SNAP. Prolonged FA latency, prolonged absent H, prolonged H reflex. All favoring a root involvement. So any questions?
Thank you, sir.
Okay. So now this is the only thing why about look at the gait of the patient that give the important message. And don't forget this particular gait. This is always we are likely to miss this kind of a plantar flexion gait. So always keep this gait in your mind. When you this kind of a gait, always ask the patient to stand on heel and toes. Such your plantar flexion gait. Okay, shall we stop?
Okay. Thank you, sir.
Thank you. Thank you. Let's see you next time.
Good night, sir. Good night, sir.
Good night. Good night. Good night.
Thank you, sir, and good night.
Thank you, sir. Good night. Good night, sir. Thank you.
Thank you, sir. Good night.